patient comes to a hospital, it becomes very expensive, and it starts to sort of block up the bed. So it's important that we do the right thing, not only morally and ethically, but also in terms of economically. So the other transition that's occurring is in the past, so this is the NHS in the 1960s. In the past, a patient would come into hospital, the doctors and nurses would tell them what to do. They say, stay in bed for a day or 7 days and we'll take care of you. So the patients were really carried through the system with very little ability to decide for themselves what they wanted. And increasingly, we are seeing patients wanting to be involved in decisions about their care. The family want to know what's going on. So the quality of care is becoming more and more important, and the ability to deliver services at the point at which the patient accesses the healthcare system. So point of care services becomes more and more important. And this allows us to now think about developing devices, both monitoring devices and imaging devices, which are portable, which are small, which can be used by the family practitioner. Why would somebody have to come in to a hospital to have an ultrasound when perhaps a family doc or a primary healthcare physician or somebody at a community hospital can use those devices? So a lot of interest in developing robust, high diagnostic, but cheap portable imaging equipment. This is something that's of particular passion of mine, academic medical imaging partnerships. And I work a lot with engineers, biomedical engineers, imaging scientists, computer scientists. And one of the things I find really rewarding is these people are very, very clever, right? You guys are very, very clever at what you do, but you don't always know what the target is. So my job is to sit with my colleagues and say, this is the clinical problem. And my colleagues come up with various solutions that we can test. So the idea is to develop novel solutions with research and to validate them in a particular research population to see if the devices or the algorithms, the software works the way we think it should work. Once we're convinced once we've validated it in the research space, then we want to bring it into the clinical space to see, does that algorithm or device work the same way in the living laboratory, which is a hospital? Because there now you have patients with a wider range of acuities. You have people who have very different phenotypes, and they may react differently to that smaller population that you validated it on. Once we've shown the novel technique, the novel procedure or software works in our patient population, we have a duty to teach other people how to use it in their patient population. So local, regional, national, and international conferences, workshops, this is all things that we do to disseminate the knowledge and have a greater impact of these advances. And then once we've done all that, we need to make sure that we test the effectiveness of these new innovations, not only in our local population, but has it improved the healthcare of our population as a whole? Has it made our healthcare system more sustainable? Is it better than what we had before? Is it efficient? So these are all the questions that we need to ask when we're having these medical imaging partnerships. And of course, it's really important to have partnerships with our administration, with government, both provincial and federal, with companies that want to develop new techniques, and also with hospital foundations where there are donors who wish to contribute towards new ways of doing things. So that's the academic medical imaging partnership. So let's follow a patient through their journey in healthcare, and let's take the ideal situation. So a patient may have some symptoms and they'll go to their family physician and they'll be able to describe their concerns, where they're feeling pain. Their physician will be able to examine them and they'll come up with a diagnosis, which is very narrow. Once they've come to that diagnosis, they'll be able to refer them to the appropriate specialist, who then may or may not decide that there's an imaging test that has to be done, and they'll refer them on to the imaging test. And the imaging test will be done in a way that's appropriate for that patient. There'll be a comprehensive radiology report, and the patient will have appropriate management. And then that patient gets better and everything is good. So that's the ideal type of situation in the patient's journey. Well, unfortunately, that doesn't happen a lot of the time. It happens for some people, but not for everybody. So in some some instances, the primary consultation may be difficult. Firstly, many people do not have a primary healthcare physician, so they have trouble accessing care. Secondly, when they access care, they may not be able to tell the healthcare provider what their symptoms are. Just think about the extremes of age. So children, babies can't tell you. Older people, they may not be able to tell you. There may be some dementia, there may be some confusion if they're ill. There may be a language barrier. So somewhere in Canada, where we have a lot of people from very different countries in the world, and that's a wonderful thing, but for many of those people, English is not their first language, right? So there may be a difficulty in communication. And of course, the healthcare provider may not have English as a first language. So if it's difficult to communicate, you may not actually get an accurate differential diagnosis, because you may not have a good interpretation of what the patient's trying to tell you. So then you may not make the appropriate referral. And so the patient may bounce around the healthcare system. They get referred to one specialist and then another specialist and then another specialist, and they're getting worse and worse. And still they're seeing a lot of people, but they're not getting the right diagnosis. Then of course, in a universal healthcare system, there are always wait lists for imaging. We try to prioritize patients on who the sickest gets seen first, but there's always wait lists, and accessing imaging can be difficult. As a radiologist, I can tell you that often we don't get the right information for the test. Often we don't get enough details. Sometimes, you know, in a few examples, we still have fax reports, and the patients and the physician's writing we just can't read. And sometimes we can't get hold of them in their office to ask what's going on. So that's an issue. And then lastly, in terms of management, still in most hospitals, patients are treated with a treatment that works for most patients, but it may not actually work for them. And we know this in chemotherapy, for example, that most regimens are built in a way that most people will get better. But that doesn't mean that that particular patient will respond well, or that particular patient might have really severe side effects, right? So that's an issue. So where are opportunities? So it's an issue, as I said. It's very frustrating for the patients and their families, and it can be very difficult. So where are the issues where AI, deep learning, a different algorithm may help? Well, if we think that communication is a problem, well, we know there's a Google translator. Perhaps we could build a language translator that works in medical sense and works for multiple languages. Just as important, if not more important, perhaps instead of using words, we could gamify the way a patient will communicate with their physician. So basically, you can use a visual directory where a patient might have a picture of a human body. They can point on that body where their pain is. They can describe in various symptoms using a visual scale what the pain is like and what quality it is like. And that might help overcome some of the difficulties with the verbal communication. And it could be used for children, it could be used for older people. And, you know, most kids now, or many kids now, are using computer games. So they're familiar with gamifying a lot of these things. So let's imagine now you have a better idea of what the patient's complaining about. You might want to have a clinical decision support tool at the fingertips of the family physician, because it's impossible for one person to have all the knowledge and expertise for every single clinical disease that might come up. So having a computer program which takes you down a certain area depending on the symptom is going to help them make a better differential diagnosis. And then once you have a differential diagnosis, you could have an AI-driven search tool that looks at all the published appropriateness guidelines that are produced by subspecialty committees in, you know, any particular jurisdiction. So if you happen to be in South America, you could look at the South American experience. You could actually look at the North American experience. You could look at the European experience. So if you've got somebody in front of you who's got certain, who you think has got a certain condition, heart failure, or chest pain, or anything, there are multiple guidelines that are published by all the specialist committees, which nobody really uses because they're too complex, and to actually access them on a real-time basis is an issue. So you could have an AI search engine which really looks at the appropriate guidelines at the fingertips for the GP and tells them, guides them to what's the appropriate test. Then you could have an AI deep learning driven scheduling system. So you have a network of hospitals that the family doc can access. He or she knows what test they want. They can look at the availability of that test in the various hospitals. They can look at the wait times. They can talk to the patient and their family in front of them and say, here's the test. You can have it, tomorrow at 5 o'clock, or you can have it the day after at 6 o'clock. What works for you? They can look if there's any indications or contraindications. They can look if there's any preparation to do. They can have instructions to how to get there, and they can hand them to those patients with the booking, just like when you're booking an airline ticket, right? It actually can be made very straightforward. And at the same time, they put the patient's details into the system at the hospital. And this includes using natural language processing to fill out the radiology request, so that the radiologist has some of the information that the family doc has been putting into their clinic notes to populate the request. And the next thing we want to be able to do is, the next thing we want to do is to develop personalized medicine. So in other words, looking at the radiomics, the genomics, and the proteomics of each individual patient, matching them to the healthcare record to look at outcomes, and then over time, building a sophisticated algorithm which lets us know for this particular patient, what's the best management treatment that they're likely to respond well to. And so that way we're getting away from the generic one size fits all to a more personalized medical information system used to treat patients. So this, if actualized, this would allow us to actually get our patients into a much better scenario. There are other aspects, and knowing that we were speaking to engineering biomedical engineers, I want to talk about some technological aspects that we might want to look at improving the quality of care. So the most important thing in a medical imaging department is we want to do things safely. So we've gone away from invasive to minimally invasive to non-invasive diagnosis. We've tried to keep our imaging tests safe by reducing the radiation dose, reducing the heat. We're using non-ionizing radiation with MR and ultrasound where we can. And we're trying to personalize the imaging techniques for the patients, but we're still, in some extents, we're still guessing what the best way of doing it with the patient. So if we looked at the thousands of patients that we image, and we fed the patients particular characteristics, their body weight, their height, their cross-sectional surface area, their radiation absorption, all these parameters into AI fields, then we could actually get personalized protocols being made for each patient when they come. And we're not there yet. So that's another aspect of imaging that AI deep learning could help. The next thing is speed. So we've had safety. Speed is important. Speed of accessing the information, speed of accessing the technology, speed of reconstructing data. There's a lot of work going in now in using AI to help speed up image reconstruction. There's a lot of work going on using AI and deep learning methods to reduce image noise, so you can actually reduce the radiation dose. We're building equipment with wide volume CT scanners that cover 16 centimeters at one rotation rather than 3.5 or 4 centimeters. And there's a whole body PET CT systems coming in now that can actually take imaging data from a 30 centimeter or 100 centimeter field of view rather than the traditional 15 centimeters. So a lot more data is coming in. So you can actually examine the patient a lot faster. And taking that data to provide more specialized information on patient health. Traditionally, a lot of imaging is on structure, is on anatomical description of something that's normal and abnormal. But we want to move away from that to looking at how the body is functioning, and particularly how the blood flow is going around various organs, because we believe that would help us characterize disease processes better. Because when you're just looking at anatomy, it's very difficult to tell one pathology from another. Infections can look like cancers. But if you're looking at dynamic models, perfusion models, then we know that certain cancers will create neovascularity in a way that normal disease doesn't, normal structures don't. And also when we're looking at treatment, if you look at the neovascularity, if it reduces dramatically, you know the patient responding to treatment, whereas if it doesn't, you might want to switch treatment. So there's a lot of interest now in building perfusion models, both to characterize disease and also look at response to treatment. It's really important to create a special experience for the patient. The patients are very tolerant. They're not always comfortable when we're doing imaging or therapeutics, but we want to make sure that the patient has a good experience. And this is where the personalized protocol come in. For example, if you're doing a CT scan of the chest and you have a younger person who can hold their breath for the 10, 15 seconds, you might want to prioritize the high resolution protocol, which takes a bit more time, but gives you more detail. On the other hand, if you've got somebody who's in pain or they're older and they can't hold their breath, you might want to prioritize a diagnostic lower resolution protocol, but which is a lot faster. So these are things that the technologists kind of do automatically, but it's not really very precise. We are looking at AI methods of motion correction. So some patients will breathe while you're doing image acquisition. And when you're looking at, for example, in CT scans, when you're looking at the number of projections you're taking, you may be able to use deep learning methods to alter some of that information that you store in a way to basically provide motion corrected images. So these are interesting things that people are working on. We have to make sure that the healthcare system is sustainable. We can't afford to keep doing what we're doing. So we need to look at the cost benefit ratio of everything we do. And we often have information on various parts of the patient's journey, but we don't have that whole information. So using AI methods to collate that information and provide patterns. In other words, where should we invest? If we want to improve the healthcare system for our patients, where's the best investment required? We're also looking at developing frugal technologies. So, you know, it's really tough for jurisdictions which have a low GDP to be able to afford some of this equipment. So myself and some colleagues, we're looking at building high quality equipment, imaging and interventional equipment, which doesn't cost a lot of money, but is very robust. So we just got a $3 million grant to develop some of these for the third world nations. And this leads to my next point, which is, sorry, I'm getting a bit of jam here. Next point is applicability. When we design a technology, whether it's an equipment or a software, we need to make sure that it can't just be used in a few hospitals in North America. It needs to be able to be used in many different jurisdictions, different parts of the world where perhaps the infrastructure is not the same. So the system stability needs to be important. So we need to develop these things. So I'm going to give you a history now. A 65-year-old, so I'm a cardiothoracic radiologist. I spend a lot of time with people with chest pain and people who have smoked, looking for lung cancer. So I'm going to give you a typical history of a 65-year-old male smoker who's got weight loss. So the person's going to attend to a family doctor or a thoracic surgeon or respirologist, and they're going to look at the risk profile. They're going to look at things in that person's history, usually a male. Have they worked in any industry which exposes them to carcinogens? Are they living in an environment which has got higher natural background radon gas? Are they smoking? How much are they smoking? How long have they smoked for? Are they exposed to secondhand smoke? What is their age? Because the older they are, the more time they have to develop cancer. Do they have a family history? So genetics is hugely important. There are some people who could smoke all their life, will never get cancer. Other people can smoke very little and they're in trouble. So risk factors become really important. Then you need a way to detect the cancer. And traditionally, in the past, they've used X-rays, not very good. And we can talk about that in a little bit. Low-dose CT scan of the thorax has been shown to be good at detecting early lung cancers. And the National Lung Screening Trial took 50,000 patients. And here's just a summary. It did to show all-cause mortality reduction of 20% with low-dose screening. And so in many places in the States, it's now being instituted, not everywhere. But here's the thing. If you screen 1,000 people who are, they're not patients, so they're individuals who are at risk, and they've got 3 low-dose CT scans, it's estimated that 780 of them will have normal scans, right? Most people will not have cancers. 180 will not have cancers, but they'll have something abnormal you need to you need to follow up. And of that 1,000, 41 will be diagnosed with lung cancer, but 4 of those would never have died from their lung cancer, whether you had detected it or not. But 3 of them will have their lives saved because of screening. So it's quite costly to put in place, but this is the kind of sort of statistics that you need to think about. There are also other ways to look at early detection of lung cancer. People are looking at sputum analysis, and people are looking at blood biomarkers to see if there is anything that we can have that's probably not as restrictive as people having to have a CT scan. Once someone is suspected of having a lung cancer, local staging is done with CT scan. So you have a CT scan of the chest, excuse me. You have a CT of the scan of the chest. And CT is really, really very good. It's very sensitive at picking up abnormalities. It's not so specific at deciding what those abnormalities are. So here are 2 patients. They both got irregular nodules, both in the left upper lobe, which is a lung cancer. They could both be lung cancers. I've seen lung cancers looking like this all the time. They could also both be infections, such as fungal disease. So CT is really good at detecting things. It's not so good at characterizing what the abnormality is. And this is where PET CT has come in for 2 reasons. One, trying to characterize nodules a bit better than CT. And the second is to provide distal staging. So in other words, in the patient on the left, you have a coronal picture. This is a PET CT, and the patient has uptake of traces. So what happens with a PET CT? You inject a radioisotope that's linked to glucose, and you inject it into the body, and the glucose will go anywhere in the body where there's a process actively using glucose. So that could be tumors, which are highly metabolic, and it also could be infections. And so this tracer will take up anywhere in the body where it's been a high rate of metabolism. So in this patient, you can see that there are nodes, there's a cancer on the right, but there's also uptake in the pelvic bone on the left. And so we know that this patient may have disseminated disease, so they shouldn't really have an operation for cure. However, what we don't know is if this area of uptake is a cancer, because PET CT, although it's better than, PET CT is better than CT, it's not perfect. So you still have to do a biopsy, as you can see here in this picture, of the iliac blade to see if that is tumor. The second thing is PET CT doesn't really discriminate well between infections and tumors because they both take up glucose rapidly. And the last thing is, if you've got a low-grade tumor, such as adenocarcinoma that's growing slowly, it's still a cancer, but it may not take up FDG, may not take up glucose. So just because it's the PET scan is negative, it doesn't mean it's not a cancer. So we still have issues with being able to characterize different types of diseases. And to illustrate that, we have this patient here on the right. They've got a hot spot. There's the CT scan. They've got a nodule. You can see it takes up FDG glucose, and it also has a node in the mediastinum. So you may say, gosh, is that a lung cancer with spread to the local node? Well, in fact, no, it wasn't. This was a fungal infection. So you have to be careful when making these diagnoses. So once you see a nodule and you say there's not disseminated disease, we need to take histology. And the way we do that in my practice is we put a needle from the skin into the nodule, and you can do that under CT, which is what we do most of the time. And I'm going to describe to you a case of how we do that, or you can do it under CR. And there are pros and cons to both of those, but I can tell you there's a real need to develop technology which is better than what we have at the moment in order to do these things safer and quicker. Once you have treatment, once you have a diagnosis of lung cancer, and if you know it's localized, the best thing you could possibly have is have an operation, right? Because that's the best chance of cure. And we've moved from having open operations with a large scar to having laparoscopic procedures with a small scar, to having robotic procedures where a surgeon will use robotic arms to make very, very small incisions. And this is really useful for some diseases, not everything, okay, some diseases. The other way of cure now has come through is different various types of radiotherapy called fractionated radiotherapy, SBRT. And in this, certain types of early lung cancers, if patients can't have an operation, they could have SBRT. And you can see on the graph on the right, what SBRT is the dose of radiation is split into multiple smaller doses, which are giving at various projections around the patient. And what they do is they focus a high rate of radiation on the tumor, but very low radiation to surrounding tissue. So the comorbidity is a lot less than conventional radiotherapy. And so this is now coming into fashion for some early stage lung cancers, and shows in some patients a similar cure rate to surgery without obviously having an operation. So I'm gonna finish off with a case history. This is actually a patient that I saw yesterday, so I thought I'd share this with you just out of interest. So he is a 65-year-old male smoker who had weight loss, and this was his chest radiograph. Now, you may not have seen many chest radiographs, so let me, so the patient's looking at you. This is their heart. They're looking at us. This is the diaphragm. So the liver and kidneys are down here, obviously the lungs. So question is, can you see the lung cancer? Tough, right? It is really tough. So this is one of the limitations of using chest X-ray to pick up lung cancers. And there were many trials done decades ago which tried and failed, because you're looking at a two-dimensional image of a three-dimensional structure. So here's the coronal CT scan of the chest, and you can see where the lesion is, circled by the orange ring. And even if you look back at the chest X-ray, you may think now you see something, but it would be tough to call it prospectively. The other thing this patient has are these black holes. So this is paraseptal emphysema, meaning these are areas of lung damage caused by smoking, and these are very peripheral in the lung, but he's also got black holes in the center of the lung. So he has paraseptal and central lobular emphysema. So we know this patient has a smoking history, and we also know he's at high risk of complications for having a lung biopsy. And so this is why I end up with patients who nobody else wants to do a lung biopsy on. And this is showing the same coronal CT scan, and I'm taking transaxial images at various slices just to show you that the emphysema is fairly widely distributed throughout this patient. And then you see this lesion is right in the middle of the lung. It's also very close to the diaphragm. So why is this position important? Well, if you have a lesion close to the diaphragm moves quite a lot with breathing. So this lesion will go up and down quite a lot, like it's on a trampoline. On the other hand, if you have the same lesion in the apex of the lung, there's very little movement of the lung with respiration, so it moves very little. So these lesions are very challenging because they're quite close to the diaphragm, and the patient has to really be able to hold their breath extremely well. The center of the lung is an issue because the deeper the lesion is from the skin surface, the higher chance of complications, an air leak into the lung and the lung collapsing. And of course, the higher chance is as the patient breathes that I can't accurately get to this lesion. Anyway, so I'm going to take you through what we do for a lung biopsy. Consent the patient. I always draw a diagram so they understand what we're going to do, and I take them through step by step. So we put a grid on. We actually move this grid round to here after this picture was taken. Then I'll measure the distance to the tumor because we have needles of various lengths, and I want to make sure we get the right one. Then what we'll do is I'll put a little marker on the skin. You can see on the orange, there's a little anesthetic needle, because in between doing the marking up here and making X marks the spot, I'll draw with an ink pen X where I want to enter, but then I'll go away, I'll put some gloves on, I'll put on some greens, I'll put on the patient some sterile drapes. So I want to make sure there's no chance of infection. Things could change, right? The patient breathes differently. So I always want to make sure nothing's changed. So I put a marker on the skin, take another CT scan. And by the way, when I'm doing these CT scans, I'm in the room with the patient. So we use a CT fluoro mode. So I'm actually by the bedside. I put the patient into the machine, take a quick picture, take them out again, do something with a needle, put them back in. So there's a lot of moving in and out of the CT machine. Now, this is the equipment we use for our procedures. So I'm just going to take you through this. I make a little nick in the skin with a scalpel just to make sure that needles can go through smoothly without any pressure. This is a coaxial needle. So it's got the outer cannula, which is hollow and allows the stilette to go in and out. So once this is in the right place, I'll take the middle bit out. And then I can slide down the center, either the core needle or the fine needle here. The core needle advances by 2 centimeters and it takes a thick chunk of tissue. The fine needle here will take a tiny, tiny amount of tissue, and both can be used for different reasons. I'll take you through that in a minute. So the next thing I'm going to do is, once I'm in the right place, I put this coaxial needle in the skin. Now, the interesting thing is, if the lesion is quite deep, this needle has to be quite long. And if the patient's skin is not that thick, you've got a few millimeters or a centimeter of this needle, and then the rest of the needle's outside. So the top of the needle is quite heavy. So every time you let go, the needle starts to drag down. So with gravity, so you have to kind of support it in various ways. So that's a bit of an issue. And of course, you have to make sure that as you go in, the patient's breathing exactly the same way. The next thing is the core. I've put the coaxial needle in, and now the core needle's going down the middle of the axial coaxial needle, and we're moving towards the target. I don't go to the target all in one step because the patient may have breathed differently and I'll miss it. So I have to creep up centimeter by centimeter. So I'll advance the needle while the patient's holding their breath, let them breathe, put them in the machine, take a picture, see if the needle's in the right place, then adjust it if it's not in the right place. I don't bring the needle out of the chest. I only make one puncture. So it's a lot of adjustments as you get close. You can already see here, there's a little black line here developed, and I'll tell you what that's in a minute. So finally, you'll get to the lesion, and you can see my core needle is open across the lesion here. And then I'll press the plunger and I'll take cores. I'll usually take 3 or 4 cores if I can. But sometimes what you find is these lesions are very, very soft. So you might get a core that looks like a little bit of spaghetti, 1 or 2, and then you keep activating the needle and nothing else comes out. That's when I'll go on to use the fine needle, because then I can put this down, the same coaxial needle, and put a syringe on the end of it and just agitate the needle in the target and get tiny, tiny, tiny samples, which can go to a different laboratory, and they can often make a diagnosis, which you can't make otherwise. And at the end of the procedure, you take the needle out, and of course, you've made a hole in the pleura, and sometimes that hole will leak air. So this air is between the chest wall and the lung, and you can see, it's called a pneumothorax, you can see the lung is starting to collapse. Now, often we'll see a tiny bit of air in 30% of patients, but in patients who've got emphysema, you see this, they will soon get into trouble, right? So you have to drain that air. And what I did is I put a chest drain in. So here's the chest drain. This is his preoperative x-ray. And I put the chest drain into the pleural space. You can see here, this is where it landed, and the lung is reinflated, and the patient was fine. We brought them into hospital overnight because he didn't have anybody to look after him at home, and so he is fine. So in summary, we've talked about transitions in healthcare. We've talked about the aging of the population in industrialized countries. We've talked about the transition from acute medical illness to chronic multi-system disorders. We've talked about the shift towards, we still have to, have hospitals, but we're trying to put more resources into community family doctors and into home monitoring to try and predict the patients who are going to get unwell before they get unwell. We've talked about academic medical imaging, where it's really important to have partnerships with biomedical engineers, electrical engineers, computer scientists, data scientists, to look at novel approaches to providing healthcare, and then validate them in the clinical sphere, looking at disseminating education across a wider jurisdiction, and then looking at the outcomes of all these innovations in terms of patient care, population health, and systems sustainability. We've talked about the patient's journey through healthcare, all the way from the primary consultation to treatment, and how various points where AI, deep learning may actually provide benefit. And I finished off with a case history just to bring this to real as to what we do. Many technical exams we do know, I believe we could do better. And if you think about what I just described with the CT, when I have a patient on the table, I'll bring them out, I'll adjust the needle, then they go back into the CT scanner, I'll press the button, wait a few seconds, the image comes up, then I bring them out again and I adjust the needle and in and out like that. So that's not great. So there's technological advances we need to do there, and that's why the C-arm is better, but the C-arm also has issues with that, which we can discuss if there's interest. So with that, I thank you very much for your attention, and I'm open to questions. I'll stop sharing so I can see you.
Yeah, thank you very much for your interesting keynote conference. So now we will move on to the round of questions from our audience present in this keynote conference on the potential uses of artificial intelligence in the patient journey overview. Okay, so now I'm going to start with one question that says, and from our, okay, this question says, how was your experience in this processing images since you finished your career?
My career is still going. It's not finished yet. But do you mean how things changed over time?
Yeah.
Yeah. Yeah, it's a thank you for that question. It's I think generally speaking, we're getting better imaging equipment, right? So the CTs are more sophisticated, the MRs are more sophisticated, you've got better PET CT scans. The computing power has increased enormously from CPUs to GPUs, so we can actually analyze data quicker and we can analyze huge amounts of data. The problem is the patients are the same. So we can do all the technical stuff, but we've not really focused much on the ability of our patients to navigate the system. So part of why I talked about the patient's journey is that we can make the equipment really, really good, and there's still areas we need to make it good. But if the patient can't access the system, it doesn't help them. So I think a lot of our attention needs to be focused on developing strategies, softwares, techniques to allow people to come to the appropriate place in the medical system. I can tell you with my experience, many patients are not well served by the health service, not because people don't want to, but because they go to one specialist and then another specialist and then another specialist and then another specialist. And that's where I believe creating these AI-driven clinical support tools, these AI-driven appropriateness tools, these AI-driven scheduling and booking tools will actually make the process more efficient. I'll give you an example. If a family doctor now sees a patient in London or in Toronto, and they want to get an MRI, for example, they will send 5 or 6 different requests to 5 or 6 different departments because they don't know which one's going to be faster. So only one of those departments will end up doing the test. The other 4 have a wasted slot. So that's money. That's a slot that could have gone to somebody else. So these are easy solutions to healthcare issues. So the nicest thing about through my career is that there's more of a realization that we have to do the right thing for patients. And it may sound odd, but we have to look at what the patient's experience is and work our hardest to make that better. Was there another question?
Yeah, thank you so much. Okay, so we have another question that says, what is your opinion of the Human Atlas project and the application of 3D printing of organoids in a biomedical research translation?
So I don't have a detailed knowledge of it, but I think it's interesting. I think we have a lot of issues with people with chronic disease, and we don't have a good solution. So I do know friends of mine who have various different parts of 3D printing, from the non-organic to the organic. I think the non-organic, there are very little in the way of ethical issues. I think with the organic, there may be some ethical issues we need to look at. But I think we have a problem that we don't have enough viable solutions for patients with the disease. So I think we need to look at all possible solutions to address that disease. So I think the aim of science is to look at potential remedies for real problems. I think the role of ethicists and politicians is to say, do we want to do these things, right? So I think those are two separate things. I think they are interlinked, but I think they're two separate things. Does that answer the question?
Yeah, I think it's a really good answer, and it's very interesting. And now we have a last question that says, can you tell us more about radiation dose reduction and perfusion CT?
Yeah, it happens to be one of my areas of interest, so thank you for that. Well, the best way of reducing radiation dose is not to use ionizing radiation. So that's the first thing. So you have to make sure what you're doing is appropriate. But the main techniques that I've looked at is manipulating kilovoltage and manipulating tube current. So for example, if you have a patient, and I'm talking about CT now, if you have a patient in whom you're going to inject iodine for a CT scan, then the iodine, the molecule of iodine has a certain what we call a kH. And if you reduce the radiation, if you reduce the kV from say a standard 130 or 120 to 100 or 80 kV, then towards the kH of iodine, then your efficiency of your CT scanner becomes, sorry, the way the X-ray photons interact with the iodine allow you to get a higher signal. So a tendency, if you're giving iodine, is to lower the kV. The problem is, though, you can't lower it too much. So if you have a slim adult or a child, you can take the kV down to 70. But if you have someone that's my size, not so small, if you go down to 80 kV, you're going to have a very noisy image because most of the photons are not going to penetrate through me to get to the detector. So generally for most adults, I won't go lower than 100 kV. So one of the ways is, and of course, so if you go down in kV, your relationship to dose is not quite exponential, but it's similar. So you get a significant reduction. How I alter MA is if I'm not putting iodine into a system, then it makes no sense to reduce the kV. I'll keep the kV at 130 or 120, and I'll drop the MA. The MA will drop depending on what the application is. For the body, it's tough, but for the chest, you can go down quite a lot. I do a lot of low dose CT. So instead of using an MA of 350, I'll use an MA of 50. And because the lung has such a large range of natural contrast, you can still use that for many things, like following up lung nodules and so on and so forth. So it's a different technique according to whether you're giving iodine or not. The iterative reconstruction algorithms we've got now, the model-based iterative reconstruction algorithms we've got now are very, very good in terms of allowing us to denoise the image, but they're not perfect, right? What the engineers think looks like a good image is not the same as a radiologist, and they lose some sort of texture. So still a lot of work to be done. Occasionally, I'll use gantry rotation, so a faster gantry rotation, so I have less projections in the image. If I can't change KV or if I can't change MA. So those are the three things I'll do. KV reduction in people who are getting iodine, MA reduction in people who aren't getting iodine, and as faster gantry rotation speed in people I can't do the KV or MA in, but I will do that.
Well, now we have two more questions from our public. And one question from Diego Garcia is, what can be the more difficult medical case to use an artificial intelligence?
What could be the most difficult case? Gosh. I think they're all difficult, and I think they're all difficult because in order to build an AI model that's predictive, you have to have a number of things. Firstly, if it involves imaging, firstly, you have to have a lot of images, a lot of exams, and they're curated and they're actually annotated, right? So the system has some structural information. You have to also have other data. You have to have outcome data. Ideally, you'd have some genomic data and some proteomic data. You'd feed hundreds of thousands of these into the algorithm as a test case, because those exams have to come from a diversity of people. So not every person, if your intake, your population that you use for data is all the same. They're all men age 40 and they're all white Caucasian. You cannot extrapolate that to women who are Caucasian. You can't extrapolate that to 80-year-old men. You can't extrapolate that to people from the South Asia or Blacks or Chinese. So you need a lot of data for a diverse population with the same condition. And you need follow-up data. And then you can plug it into a system to say, produce me an algorithm. And then you have to test it on people who haven't been part of your solution to make sure it makes sense, right? So a lot of it is still, you'll see a lot of publications, small groups with a really good explanation, and it looks really good. The problem is when you try it in a different patient population, it doesn't work as well. So this is the problem with AI. It's got a lot of promise, and there's reasons why it should work well, but nobody really has the time to do the right science. And I know there's IBM Watson, and I know there's other companies that are looking at large data sets, but you have to look at the information they're taking into the model. And you have to say, where is that information coming from? How well was it curated? How well was it annotated? How well was it correlated with all the other things that go on in that patient? And so I think a lot of people, a lot of institutions are interested in this, and I'm convinced that we will get AI algorithms that work. I'm not so convinced that there's any that I've seen right now, which I would rely on more than I rely on usual clinical judgment. Hope that answers the question.
Yeah. Diego says yes, it's a really good answer. So, well, we have another question that says, from Nicolas Silvas, is it difficult to validate and get permission for an artificial intelligence solution in order to be used in real cases?
The way you would do it is, and the answer is yes, but the way you would do it is when you're validating it, you wouldn't use a solution to make a decision, clinical decision. So you would have a parallel process. You would know what already happened with the patient, but you would anonymize the patient's, let's just say you're looking at a medical ward over a year with everybody with heart failure, right? And you have all those details. You have all the imaging, biochemistry, hemodynamics, the medications, the ages, the genders, you have all that detail. And you follow the patients over a year, let's just say. And then you take all that patient's data, then you anonymize it, okay? And then you start building your AI algorithm. The next time you want, and you validated it. So next time you want to use it in a patient, what you would do is you'd have the physicians decide what they would do with the patient. And then separately, you'd have your algorithm say what they would do. And so the algorithm's not making the decision, but you, in retrospect, and say, okay, well, did the patient do well? What would the algorithm have predicted, and would the patient have done better? That's the first, so that would be the phase one of clinical validation, because no one's gonna, right now, the FDA, Health Canada won't approve an AI algorithm for decision-making because they don't know what goes into making the algorithm, right? So no one's gonna do that. But if you can show in parallel, in multi-center studies, across different jurisdictions, that actually time and time and time again, that AI algorithm predicts better than clinical judgment, or, you know, AI plus clinical judgment is better than clinical judgment alone. Now you have published evidence that it works. Then you do your phase 3 data to say, what if we use the AI instead of the clinical judgment, right? So that's how you would do it. I don't think you could bring one in straight away and substitute it because there's so many unknowns. about AI. And of course, the companies that are building these models, they want to make money. So they're going to tell you it works. And nobody's going to believe them until it's shown.
Yes, thank you so much. And well, we have, I think, 2 questions more. Yeah, it's really interesting that we have a lot of questions, but let's continue with the last 2 questions. That one says, do you know of any image database, either CT or others, that are freely accessible to us as students?
Yeah, I do. And I could send Nicole the links to them. So there's a few. Yeah, and there's some really good ones. So there's some on X-ray, there's some on CT. So I could certainly do that. Yeah.
Yeah, if you can give us the link, will be really useful for us, because most of us are students. And well, let's continue with the last question that says, what software do you recommend to start projects using artificial intelligence for the medical area?
You know, I don't know what's useful, but I can tell you what I would find useful. I think if you look at something that we do a lot of, and you could really document it time and time again, and then say, is there a better way to do it? That would be the ideal thing. So interventional radiology, for example, the reason I showed you that thing with the lung biopsy is if we fed the way I do a lung biopsy, or my friends do a lung biopsy, my colleagues, into an algorithm, and you fed enough patients in it, and you show the times we're successful, the times we're not successful, the algorithm would, with a deep learning methodology, would start to learn, you know what, the times when you're most successful is when you do it this way. The times when you're not so successful is when you do it this way. And then you could actually use predictive analytics real time during a procedure to say, you know what, if you just put a bit more angle, just a bit more angle, and you might be actually get in first time. So it wouldn't replace me holding the needle, but it may actually assist me in saying, here's a better way to do it. For me, you want to look at something that has a definite outcome, right? Because if you're going to build an AI model and it has a sort of soft outcome, you have to have thousands and thousands and thousands of bits of data. But if you have a hard outcome, like did you hit the target or not, and we know that from when we get the histology sample back, whether you're doing it with thyroid biopsies, or whether you're doing it with liver biopsies, or whether you're doing it with lung biopsies, any kind of technique-based thing has definite outcomes, has a standard procedure. You could build an AI model to sort of help with that. And I think that's what I would look at.
Okay, thank you so much for your precise answers for all of these questions. And well, those will be all the questions. And we thank Dr. Narinder Paul very much for his great presentation today. And is there anything that you want to add to this presentation?
No, I think thank you for inviting me. It's always nice to talk to people who are very smart. It's always nice to talk to people much younger than myself. So I have hope that future generations are going to be doing some wonderful things. And I'm very open to having further conversations. And we have a very big imaging science structure here. So part of our job is to build partnerships. So if there's any interest in your society, exchange of students and that kind of stuff, we're always open to having that conversation.
Thank you so much. Okay, now we are going to take a picture in order to remember this memorable conference. And I'm going to wait 1 or 2 minutes. And if all our public can turn on their cameras, it will be really nice. So please, please turn on your cameras. Don't be shy. Okay, Diego. Hi, Diego. Hi. Hi, Nicole. Okay, 1 minute more. Okay, so is there anyone that wants to turn their camera? Yeah, I think we are waiting 1 more minute. Yeah. I Okay, so now I'm going to take the picture. Please prepare your smile. Okay, so in 3, 2, 1. Okay, that's a beautiful picture. And I'm going to take another photo. It will be published in our social media. So 3, 2, 1. Okay, thank you so much, Narinder and our dear public, for this really beautiful picture, for being present today. So, again, thank you, Doctor. We are delighted to have you in a next opportunity. Likewise, we thank the audience for their attendance, and good afternoon. And I invite you to be present in the next contest, and also in the next keynote conference that is called Advanced Technologies of Brain by Metin Akai. Thank you so much. Goodbye.
Bye now.